join you with that. Neither do I. Okay, waiting on a few more students. We got some ground to cover today. So nobody did anything fun this weekend, huh? Okay. Do you all see
I
your,
did.
what'd you do?
My auntie and my uncle came down here for my auntie birthday party, so I
Oh,
went there to the Tokyos. I ain't stay
oh,
long. I ain't stay long because I had to study, so I brought my cards with me though.
I'm nursing a cold, so bear with me. Um, I think we'll get going, and whoever needs to come in late comes in late. So, welcome to week 8. Couple of things. Over the weekend, I posted exam 2 grades. For the most part, this as a class, you guys did really well. Really proud of you. Um, um, I sent out some messages over the weekend. Oops. One more student, two more students who are waiting on it. All right, so I sent out some messages over the weekend. I sent out, if you score below a 78, schedule a time to meet with me. I've already heard from a lot of students overall scheduling times. That's great. I'd love to review the exams with you. I think it's helpful to review some of the concepts that you struggle with. I hate to say the word missed, but concepts that you struggle with. So please take advantage of that. If you score below a 78, set up a time to meet with me. If you scored above a 78 and you still want to meet with me and review the concepts that were maybe a little bit low, I'm happy to do that as well. Whatever you want to do. And then I also, for students, since I turned the homework grades off, the grade you see now is your straight up KGA. Okay, so that is your 2 exams, 4 quizzes. That's your straight up KGA. Homework grades are off. So if you were below a 78 with your overall KGA, I sent you a mid-module assessment. I know we're done midterm, the end of week 6. I always like to wait till the end of week 7 to send those out because a lot of students do improve their grades significantly with exam 2. And that, as I predicted, happened, which is great. So if you got a mid-mod assessment email from me with that attached, if you could schedule a time, and really what we're talking about is what can I do to help facilitate you, assist you, support you going forward for the rest of the term so that you are successful. All right. So one of the things that I've noticed this particular term is all the students, and I have 3 different sections, all the students who want to meet. They want to meet just to chat. They want to meet to review exams. They want to meet to review their mid-mod assessment. They want to meet for tutoring. And so the amount of student outreach that I have had this term has been significant. And for me, that's what it's all about. Meeting you guys, getting to know you guys, figuring out how I can help and assist you be successful in this class. All right, so keep those requests coming. I'm pretty open when I can meet, early mornings, evenings, weekends. And I usually ask you to determine what works for you, since I can be, for the most part, really, really flexible. All right, so keep those requests coming. I appreciate it. Let's see. What else? I want to talk about the HESI prep. Please tell me you're all working on your HESI prep assignment. Okay, that was given to you in week 1 with the expectation that that is a project you're working on throughout the term. Because what it actually is, and I explained this in week 1, it's your study guide. You're building your study guide week by week for your HESI, right? So I hope that everybody has started working on it. After today, and even before today, throughout the first 6 weeks of class, or 7 weeks of class, quite a bit of that HESI prep can be completed. And remember, every box that you see on the HESI prep, we're not going to cover specifically in class, but we're going to cover the concept that those boxes fall within. So if you don't see it, if you don't see the information from those boxes in your notes, you don't see it in our lectures, you're going to have to go back to your books, your 3 books, and get that information. Okay, I told you in week 1 that this community HESI is very med-surg focused, right? So I don't cover a lot of med-surg in this class, but your med-surg book has all the information you need. Who's in the waiting room? I don't have anybody in the waiting room. Toya's in the waiting room. Who's Toya?
Latoya. I'll call Latoya. Brooks.
Oh, Latoria. I don't have, she's not in the waiting room.
Oh, she sent me a message and just said she was in the waiting room. Okay.
Make sure she's in the right class,
Okay, I'll tell her.
because I have nobody in the waiting room.
Okay.
All right. So, like I said, a lot of those boxes in that HESI prep are med-surg focused. You're going to have to go back to your med-surg book and get the answers to that, or get the information. And remember, those topics on the HESI, that HESI prep, are topics that are covered on the HESI. Okay, so don't blow off that assignment. It's a really important assignment. It's a really, I think, accurate assignment for what you're going to be seeing on your HESI. Okay. Questions about that? I just want to make sure everybody's working on it, because it is due at the end of next week. And if you wait to start doing it this week or next week, it's going to be a long, drawn out assignment for you. But if you continue to do it as we cover topics, I think it will make a lot more sense and will be a lot more helpful. Does that make sense? Just trying to help you out here. Okay. Let's go ahead and let's take the quiz. Couple of things that are different about the quiz. All right. I have to set a time. I have to set a time limit on it. I wasn't doing that before. I need to set a time limit. So there's a 15-minute time limit on it. And the other thing there is an access code. Okay, so it's not that I was setting them up incorrectly, but not as much attention to detail as I should have. All right, so hopefully that won't impact anybody. But do you see the quiz in your quiz 5? Do you see that in your grade book? Okay, so the code is my last name, spelt the same way, Marvel, M-A-R-V-E-L, capital M. So go ahead and get started on that quiz. And again, it's 15 minutes. We'll go over the quiz after, and then we're going to cover week 7 and 8.
Ms. Marvel, I don't mean to cut you off. I don't have it in my grade book or my module. I'm only up to quiz 4. I don't see 5.
You need to refresh. Does anybody else see it?
You still waiting? Ms. Marvel, and Toya says she's still in the waiting room. All right, I refreshed it.
Nope, I don't have anybody in the waiting room. I don't know what.
Not tripping. I went to the and I went to.
She said she don't have nobody in there. I'm just gonna send you the code again.
Hey, I'm gonna mute Everybody that's not muted.
Oh, I'm about to mute right now, Miss Marvel. I'm sorry. I thought I muted.
Okay, that's okay. And so if you need to communicate with me, please communicate with me through the chat. Okay? Has everybody there she is. I have her. I have her.
This is your registered nurse, RN.
All right, so everybody submitted? It's beyond, everybody should be done. It's beyond the 15 minutes, I believe. Anybody still working on it? How'd you do? Awesome. Love thumbs ups. All right, let me double check and then we'll. Okay, let's see. Janisha, have you all done? Janisha, you done?
Yeah.
Okay, good. All right. All right, let me share my screen and we'll go through it. It's kind of wonky donk how it's set up with me, but we're just gonna have to go one question at a time. Can you guys see my screen? Yeah? Okay. All right, so get a couple of infection control questions. Which of the following are effective parts of infection control to reduce the incidence of healthcare associated infections? Select all that apply. What do we have correct here?
I picked everything but C.
How does that look?
Yeah.
I mean, it's nice to explain what we're doing, but it's not completely necessary, right? We always want to use PPE, hand hygiene, and be following the environmental infection control protocols, right?
Yep.
Feel like I'm taking the quiz.
Mhm.
All right. In addition to observing standard precautions for the client with primary TB, Lisa should also observe which of the following precautions. What's most important for TB?
Airborne.
Airborne.
Good. I mean, we should all know that, right? Have you covered TB and have you covered the topic of infectious diseases and prevention in other classes?
Mm-hmm.
Oh, you have? What class
Mhm.
have you covered it in?
Med-Surg.
Med-Surg. Okay. Okay, airborne precautions. This is on the tail of the last question. Requires which of the following precautions? Select all that apply.
All but A.
Yep.
Mm-hmm. That's what I picked.
Does that look right?
Yep.
And this was in your notes
Yeah.
for this week,
Yeah.
right?
In effect, I only studied for freaking 30 minutes, not even 30 minutes.
Which of the following medical asepsis principles are sufficient for in-the-home contact precautions?
all of them except for the last one.
Yeah.
Does that look right?
Yes.
Yep.
So is this like a review for you?
Yeah. Yeah.
That's good.
Yeah.
No, and it reinforces, right? Okay. Sarah, the nurse, knows that a client needs to understand that the HIV test cannot identify infections that have been acquired within the prior 12 weeks or 3 months before the test. Which of the following statements by the client indicates that further teaching is needed? So what are we looking for?
A negatively framed
C.
question.
It's
Pardon
C.
me?
It's a negatively framed question. And it's C.
Correct. Right?
Mm-hmm.
Everything else is correct.
Yeah, everything else is right.
So if you right, every other answer is correct, but this C is not correct.
Right. Because you
That's
want to
why
get
we
counseling. It don't matter if it's before,
Mhm.
if you haven't got your test results yet or not.
and we need to get retested in 3 months.
Retested in 3 months, yeah.
Right. Right.
That's why I used to wait 6.
Okay, disasters. We'll cover that this week. Natural disasters can be devastating to the community. The nurse is providing a yearly education class to the community. which statement by one of the community members indicates further teaching is required. So what are we looking for? What kind of question is this?
Negative.
Wrong one.
Correct.
Let's see.
What do we think?
C.
Yeah, see.
Why? What's wrong with that?
It's
It's in the notes
incorrect.
one, but think about it. Even if it wasn't in the notes, what does sitting it out for 24
What
hours
the clause gonna do? Nothing.
it got to do with cleaning it? That's crazy. If anything, you just gonna get
Right.
lint in your water.
Right.
That
And this
part.
question was in your notes as well.
Yeah.
Yep. Smallpox.
Okay, this is this is a very distinguishing factor between chickenpox and smallpox. What is found on the palms of the hand or the soles of the feet?
The little
Smallpox.
rashes, the little small pox.
Smallpox.
Oh, this must be the one I got.
Which actions by the nurse accurately indicate understanding of proper management for the client that's been exposed to a toxic chemical spill? Select all that apply.
It should be all.
It should be all, but I left off. For me, that must be the one I got the point 25 for, 9.25. So I mean 75. I didn't put clothing should be placed in a plastic bag. I mean I guess I see why now, but I didn't put that.
Yeah.
And I didn't
Absolutely.
It was in your notes.
C on that one because I
Pardon me?
thought that I didn't put C. I put everything except C because I thought it was supposed to be like longer than 15 minutes.
Well, I know in the notes it do say when you take the Kelly, when you take the what is it, contact lens, are you supposed to rinse for 10 to 15? But
10 to
I
15.
feel what you said. When your eyes get so many, you are technically supposed to rinse.
And absolutely
Okay.
clothing should be placed in a plastic bag for disposal.
Yeah, that makes sense. I had stuck on that for a minute. I was like, well, is the toxic chemicals gonna go through the bag? You know, my brain started doing that extra stuff, but I understand.
Yeah, you're overthinking it.
Yeah. So it's cool though. I mean, shit, I did good. Other than that, I just didn't do that one.
Okay.
What you
The
got?
sharing of information from one healthcare setting or provider to another is critical for community-based care,
I'll do that.
especially with clients that are trying to make the transition between hospital to home. Which is an example of that? What
C.
this is the correct answer, but this doesn't make sense, right? Well, we don't need the emergency room staff involved.
Hospital.
We don't need post-surgery staff involved because there's no
Right.
indication that we're coming from surgery. And pharmacy, maybe not. But one of the things that's critical in that transition is there has to be planning from the acute care facility to the home health staff. Otherwise, how's the home health staff going to know what the needs of the client
Right.
are? Right?
Yeah.
Right.
Then our last question. Physical neglect refers to failure to provide food, clothing, shelter, hygiene, and
Necessary medical care.
Necessary medical.
medical care. We'll talk about the difference between physical neglect and emotional neglect. I know hopefully I got a 10. Yay, got a 10. Okay, we'll talk about that a little bit more. Hang on. Using the restroom. Okay. All right, let's pull up our notes. We got a lot to cover, and I want to cover. I do have a Kahoots for week 7 and 8. If we get to it, fine. If not, I'm going to send it in my email to you with this class recording. I mean,
Okay.
Kahoots, yeah, they're fun to do it as a group, but I also think Kahoots is also very effective to do individually because you can take your time, think about the question, read the rationale. Okay. So if we get to it, fine, but I'm more focused on getting through the content. Okay. So let's review some things about infectious disease prevention and control. Okay. We know that when we're talking about the environment, so put yourselves in the community setting now, not in the hospital floor. You're in the community. All right. Lots of infectious diseases, communicable diseases happen in the community. Look at COVID. All right. Look at the flu. Look at chickenpox with kids. Lots of infectious diseases fall in the community as well as the acute care setting. So when we think about the community, we're thinking about the environment. It could be related to physical, biological, social, and cultural factors. Okay. The first thing we need to talk about is the epidemiological triangle. Okay. So all these environmental factors, biological, physical, social, cultural, they all can facilitate, one or combined can facilitate the transmission of any kind of infectious agent. Okay. Transfer to a host, which is us. And depending on what the environment looks like, will depend on how prevalent the illness is. Okay, so we have a host. That triangle consists of three things: an agent, a host, and the environment. What's the agent? It's the bacteria, it's the virus, it's the chemical. What's the disease agent? Is it pneumonia? Is it COVID? Is it meningitis? Is it chemical in nature? Is it a sarin gas? Is it an anthrax? That's the agent. You have to have an agent, right, to infect a host. The host is us, right? It's a living being. Okay, you have to have an agent to infect the host. And then when you bring in the environment, what in the environment impacts how that agent and host are reacting? So let's do a couple of examples. Let's go back to COVID. Let's say the agent was COVID. The host was elderly clients in a nursing home. In the environment's a nursing home. All right. Those clients are going to get a lot sicker, correct? They're in a long-term care facility. They're elderly. And it's COVID. Another scenario. Let's take COVID as the agent. Let's say we have a high school football team. Who's the host? And the environment is the school setting. That group, based on what we know now, was much less likely to get sicker. Does that make sense? So let's take pneumonia. Pneumonia is your agent. Your host is the elderly in a assisted living home. That's the environment. Versus an elementary school classroom, pneumonia, and the environment is a school. Kids are less susceptible to getting pneumonia from each other. Does that make sense? And what I'm trying to communicate is whatever the agent is, whoever the host is, and whatever the environment is all going to look different with every scenario.
Could
Right?
you say that?
Let's say you have a host. Let's say I'm sick right now. Okay, my immune system is a bit compromised. Okay, I also finished radiation for breast cancer. So my immune system's a bit on the weak side. So am I more at risk for getting sicker from a cold than say Crystal would if Crystal's healthy and she's exposed to a cold?
Yes.
Right?
Yeah, you would be. Your body
Yes,
is going through radiation and all that.
Yeah. And so let's say, and let's say the flu. elderly are much more likely to get severe cases of the flu. How many times do we hear of elderly people dying in hospitals from the flu over the course of the winter? We don't really hear that about the kids or healthy people, right? So my point is, we have what we call the epidemiological triangle. All these three, you could come up with a gazillion scenarios, right? But you need an agent to infect a host. And how healthy is that host? Is the host healthy? Is the host not healthy? And what about the environment? Are you cooped up in a long-term care facility or are you out in the open? And what other factors from the environment? Let's go out in the community and do, let's say you have your agent is air pollution, right? Because you live in an environment that's has terrible air quality. It's a transportation hub, whatever. And let's say your host is somebody with asthma. Is that air pollution going to affect that host more so if they have asthma versus not have asthma? Yeah, of
Yes,
course. Right,
their lungs are compromised.
right. So do you see the connection with that? There's no right answer. It just depends on how severe that agent is. There's a group of people who are much more affected from COVID, right? That was the elderly. Elderly is also much more affected by flus. Okay. I don't know if I explained it by giving the examples were helpful for you to just understand the concept of it takes all three. Takes all three to paint the picture of what's happening. Okay. Passive immunity. You're passing it on person to person, right? Either from mother to a baby or IV administered antibiotics, acquired immunity. You have acquired immunity to a disease from previous infection or vaccine. With COVID, that's where all that talk about natural immunity came up, right? If you had COVID, that was a hopeful acquired immunity. Okay, I'm going through this quickly because there's parts I want to cover more in depth. Incubation period, right? It's the time it first appears. It's the time between the invasion of the infectious agent and then you get symptoms. For example, I was around Patrick last Wednesday, I think, when I took him to therapy. He was all junked up. Okay, so that's when I was introduced to something was going on. I didn't really get sick until Saturday. So that was the incubation time I was with him to the time I got sick. Okay, what's the difference? We need to know the difference between epidemic and endemic. Let me start with endemic. I'm right here. All right. Endemic, an example of an endemic would be the flu. It's not going away. It's endemic. It's always going to be here. COVID is pretty endemic now. It's always going to be here. But epidemic is just a bit different. It means that, well, let's take the flu, for example. Even though the flu is considered endemic, we may have periods of epidemic with the flu. And those periods just mean that last year, 10% of the population got the flu. This year, it's up to 20. So for this winter, the flu is epidemic. Does that make sense? Epidemic is temporary. So originally COVID was an epidemic. Now it's become endemic. Now, if we go up again, we may hit a period of an epidemic level of COVID again, but it's always going to be endemic. Proper hygiene we talked about. We talked about contact precautions in the quiz. You don't need to know about that. Okay, surveillance. As a school nurse, I was always surveilling stuff. Okay, there was always stuff going on in the school. Surveillance is like investigating or monitoring. So I'll take COVID. When COVID broke, all I did for 2 years is surveil kids, surveil staff. Which direction is this going in? All right, so it's observation, surveillance, going through the nursing process, collecting information, trying to analyze, interpret, talk to the staff about what's going on. You know, there's 3 first grade class. One class has no COVID right now. One class has 2 cases and another class has 10 cases. Right? Trying to establish trends. Okay, the class with 10 will probably go to 20. How can we keep the class with 0 cases protected? Right? We're always trying to surveil and observe. We're trying to reduce morbidity and mortality. During COVID, I was trying to help lessen the spread by keeping kids out of school that were already infected. You know, did they stay home for the right amount of time? There are different kinds of outbreaks. Okay, point source out, and I've highlighted these. There's 4 we need to know. Point source. Everybody's exposed to something at the same time. All right, so that could be a gas leak in a train or a gas explosion in a train. Everybody is impacted right then, and everybody will get sick. Intermittent, right? You have an exposure over a period of time. Intermittent, that's what intermittent means. People get sick at different times. A good example of that is food poisoning. Let's say you go to a restaurant and their batch of lettuce that they ordered was bad. But they didn't realize it until people started showing up at the hospital or the health department. And so people got sick over a period of time because they were using this lettuce batch for 5 days. Make sense? Mixed. A mixed outbreak is when one person is exposed to a source and then it just goes person to person, like the flu. And then the last one is propagated. You don't typically have a common source. It spreads gradually from person to person. A good example of that is TB.
I got a
So
question about,
go ahead.
I got a question
Yep.
about the mixed outbreak. Is
Uh-huh.
it the infection or it's like the people?
The example I give is the flu just passing on from person to person. I mean, flu is just one example. What would be another example of something that would be a mixed outbreak? What about kids with chickenpox? Right? You pass a person to person and it just spreads from person to person to person to person to person. It just keeps going. So you may have an outbreak of chickenpox in a preschool class that may last over 6 weeks. Somebody breaks out on day 1 and there's still somebody breaking out a month later. Does that answer your question for you? Okay. when developing programs with regards to infectious disease training or health teaching, you have to do a needs assessment. Okay? And there's 4 stages of that needs assessment. Preactive stage, the nurse is projecting out future needs. Reactive stage is the here and the now, determining which problem it is and using the past identified needs. Don't focus too much on this. I'm just going through it. Okay? Inactive defines the problem based on existing health status, and interactive describes the problem using past data to prevent future need, project future needs. So really what I want you to know is that as we're doing community-based programs, we have to start with a needs assessment, and the needs assessment has 4 stages. Okay? We know that vaccines are one of the most effective methods of preventing and controlling communicable diseases. Okay? Let's say you're in the schools, and this happened to me all the time, and you're working with families that have chosen to do a exemption, right? You have personal exemptions. I don't want my kids vaccinated for personal reasons. It's none of your business. Medical exemptions, they have some kind of a medical diagnosis condition that prevent the doctor saying vaccines will actually hurt this child. And then you have religious exemptions. Based on certain religions, we don't vaccinate. How do you work with, if you were the school nurse, how do you work? What do you think is an effective way to work with parents if they're refusing vaccines? And I can tell you the numbers are starting to go up, because I still have contact with some of my teammates in the district I worked with. And this year in particular, the vaccine exemptions have never been higher. For whatever reason, personal exemption, medical exemption, religious exemption. If you were a school nurse, what would be how would you approach parents? And what might be effective? I mean, we can't belittle them, right?
I mean,
we can't judge.
You could state the fact that people have put out there, researchers have
Exactly.
put out there. However, you know, I'm a parent. My kids are vaccinated, but if I chose not to do something, you're not going to force me. I'll listen to you. You feel me? But, you know.
Right. So,
Probably
Charmaine,
like teach them
bingo.
teach them like ways to prevent and getting infected, like staying within the country and things like that.
Exactly. The straight up answer is we can't judge, we can't force, so we simply continue to teach and educate. Right? Educate about how vaccines are one of the most effective ways of controlling and spreading communicable diseases. Okay? Working with parents, we always had a kind of a go list, where if we had a confirmed case of pertussis in the school, we would contact those kids, we would contact the parents of kids that didn't have those vaccinations for pertussis first. Say, you have the option, you know, maybe keep your kid home from school until this passes. Okay? Okay. Couple of specific infectious communicable diseases: HIV, hepatitis, TB, and STDs. Okay. There's a difference between, with regards to STDs, they're either bacterial or they're viral. And as you read in your notes, bacterial we can treat, viral we cannot. Correct? I'm sure you went through this in MedSurg. Some bacterial examples of STDs: gonorrhea, syphilis, chlamydia, treated with antibiotics. However, the STDs that are viral can't be cured. So really what you're working, this is going to be a chronic disease, and it's symptom management over the lifetime. Okay. The one particular STD I want to mention is syphilis. And I'm just up here in this top paragraph. Syphilis can be transmitted transplacentally. What does that mean?
It can go from the mother to the baby.
Right. Exactly. If syphilis in a pregnant mom is untreated, and that syphilis is transferred transplacentally, that can create some very, very big problems. Right? Stillbirths, premature births, blindness, deafness, facial abnormalities, disabilities. So I just want to point that out. I'm not going to go through in specifics, but I want you to review chlamydia, gonorrhea, syphilis. I've tried to include the most important bullet points for each. There's a couple things I want to mention about herpes, whether it's herpes or genital herpes. This is an example of something, of an infectious disease that is viral. Okay, therefore it's incurable. Okay, it can be treated with antivirals. And this I added. That's why it's in blue. So I want you to, let's review this. So take notes on this. Clients with genital herpes should definitely inform their partners of their disease, right, to help prevent transmission. Petroleum products should be avoided because they can actually cause the virus to spread. And the notion that genital herpes is only transmittable when you have visible lesions is false. All right. So anyone not in a long-term monogamous relationship, regardless of current health status, should try and follow safer sex practices. So the point I want you to take from that is informing your partners is something that should be done, and not assuming that it's not transmissible just because there are no active lesions. Okay. Another viral infectious disease, hepatitis. And just have a knowledge of what's the difference between hepatitis A, hepatitis B, and hepatitis C. And it's spelled out for you in these 3 paragraphs. Okay, so just know the difference between the 3. HIV, we talked, really the only thing that I would like for you to understand the concept, we went through in the quiz. Okay, we know that HIV, we haven't gone through this part, but HIV is spread through sexual contact, sharing of needles. It can be transmitted vertically through breast milk, pregnancy, mom to baby, possibly in blood transfusions, after a needle stick injury, or you have a high-risk exposure. We know that open lesions anywhere from whether it's an STD, open lesions in inflamed tissue increase your risk of HIV. And HIV, as we reviewed in the quiz, HIV testing is antibody testing. And it can cause false negatives for up to 3 months or not be detected, right? So that's why we went through in the quiz, it should be rechecked in 3 months. Okay. The other thing about HIV that's an important fact HIV infected people who live in close quarters with others, say in prisons or correctional facilities, they need to be really screened before admission into these facilities, right? Because a person with HIV is much more susceptible to other opportunistic infections that may be common in close quarters, such as TB. TB is pretty common in correctional facilities, prisons. So somebody who comes in with an active HIV infection is much more susceptible. Think about it, that's that agent-host environment. Right? Let's say the agent is HIV. The host is somebody that's going to be going into the correctional system. And the environment is a correctional system, which by virtue of how they're housed already has very high risks for TB. So that person infected with HIV is going to be much more at risk for contacting a potential TB if there's an outbreak, right? Does that make sense? Okay.
Yeah.
TB, we've covered mostly everything in this section from the quizzes. Bioterrorism management. Think about the community. Yes, there is bioterrorism and disaster management that can happen, obviously in the hospitals, of course.
Excuse me.
But think about the risks out in the community, right? Let's talk about disaster for a minute. Disasters are either natural or man-made. Natural disasters, right? They occur naturally. Earthquakes, droughts, hurricanes, man-made disasters. We create man-made disasters. Pollution, warfare, fires, water supply contamination.
Global warming. I'm just playing.
Global warming. Global warming.
Miss Marva, I sent you a message in the chat.
Oh, do you want me to stop and read it now? Or can it wait till after?
Well, I could just tell you what it said. I'm gonna have to get off and go get my husband, but I'm coming back on.
Okay.
Okay.
All right. Sounds good. Thank you for letting me know. So one of the things we would do as a community nurse, because we're always going to be involved in disaster preparedness, disaster teaching. Okay. Here, let's say we're working in the community. We want to help the family prepare for a disaster. They have to put a kit together. What do they need? Well, several things. Stock enough food for 3 days, review the kit every 6 months for any expired items. Does everybody in the family know where the kit is located? Does everybody know how to turn the utilities off in the house? One day last week, I don't know which day it was. I don't know if anybody was impacted, but they had that big phone outage. Remember that last week? I think it was mainly AT&T, but originally they said it was Verizon and T-Mobile and everything.
Yeah, mine went out for
Okay.
a few hours, about 6 hours.
Okay. So during that time, were you like, crap, how am I going to get in touch with my kids? How am I
Yes,
getting... Yes.
that was the number one thing.
Yeah. So I wasn't affected, but I started thinking, dang, I really need to come. We as a family need to come up with a plan of is everybody prepared? Does everybody have a kit ready? Do we have a meeting place? How do we know everybody? Anyway, it just made me think, and I knew I was teaching about this week, but it really made me think about how unprepared I am, not only with supplies in my house, but if my phone went out, how would I get in touch with anybody? How would anybody get in touch with me to see if I'm doing okay? It was just, I mean, I know I'm being a little dramatic right now, but in the big scheme of things, I was very unprepared.
Right. You're right.
So preparedness is one of the roles that community health nurses, if they're working in the disaster management area of community health, it's all about preparedness, right? And I certainly failed that test last week. And I even had a phone that worked. And of course, I texted a couple of my kids and they're like, Mom, whatever. But they don't take it seriously either. So I got some work to do. So nurses are expected to participate in any part of a disaster, whether it's the planning, whether it's the actual impact stage, the preparedness stage, the triage stage, the post-recovery. We're just expected to know what to do in each of those areas. You know, if you work, I'm sure that your facility organization has disaster drills. Those are exactly what those are for. In the schools, we have our fire drills, our evacuation drills. That's exactly what those are for. Because when a disaster hits, you know, you're expected to be jumping in there and helping with whatever part of the disaster they need you to help with. One of the purposes of disaster preparedness or disaster exercises is it's to see what the response is. How did it go? Did your master plan come together? Did 911 get there? First responders get there? Did people communicate? We don't really think about disaster planning, disaster preparedness proactively as much as we should. There's one particular agency I'd like you to know about. It's called the National Response Framework, and this is in relation to disasters. They provide, I mean, we have FEMA, right? That's kind of the big organization, Federal Emergency Management, right? But within FEMA, we have a National Response Framework. They are going to provide specific needs in the community, right? Particularly transportation, temporary housing, medical resources, search and rescue, and firefighting. I added this to your notes. I expanded this to your notes. So take note of this. When do we consider water to be safe for drinking? There was there was a question about this in the quiz, but I want to be a little bit more specific. Boiling 3 to 5 minutes.
Mm-hmm.
Household bleach, 1 ml, which is 16 drops, and then let it stand for 30 minutes. Okay, removing hot water from hot water heaters and commodes. As we talked about, this last part is not correct. Allowing water to sit for 24 hours or pouring water through layers of cotton towels does not adequately render water safe to drink. Okay? When disaster happens, I want to mention the impact stage. We as nurses, when disaster happens, have to acknowledge that make the assumption everybody's in the impact stage. Right? So let's say you're working in a nursing home or you're working at the hospital, wherever. Okay? The goal is to get everybody to a central place for safety. We're not taking patients back to their room. Let's say we're in the dining room. We're not taking patients back to their rooms. We're not taking patients. We are trying to get everybody to a safe location. Does that make sense?
Yes.
There, when we get everybody cleared to a safe location, then we can start to triage. Does that make sense? I'd like for you to know about a couple of agents, chemical agents that have to do with bioterrorism. And I've listed them out here for you. Really what I want you to know is what systems are impacted. So with anthrax, with smallpox. Okay, you can read about it, but no, in that, I think this is on your HESI prep, anthrax. Smallpox, we talked about smallpox. Palms of the hands, soles of the feet. Okay? Sarin. When you have a potential sarin gas exposure, you're going to see severe respiratory distress. Okay? When you see anthrax, potential anthrax exposure, you're going to see skin sores, GI issues, respiratory issues. Smallpox, you're going to see skin issues. And sarin, you're going to see respiratory issues. We have other kinds of infectious diseases or communicable diseases, foodborne. I think I talked about this in a previous class. When I go to a fast food, I assume that everybody is doing their due diligence, right? Preparing the food, cooking the food, storing the food as they're supposed to. Okay, so here's some tips for foodborne illness, food safety. We also have waterborne illnesses. You know, what if there's a dump of chemicals in a water supply? Or what if there's animal or even human contamination, fecal contamination of water supplies? When we hear about natural disasters, we often hear about cholera or giardia, right? Which are GI issues related to contaminated water. And then we also talk about vector-borne infectious diseases, Lyme disease, maybe due to a tick, Zika, mosquitoes, malaria, mosquitoes. Okay? So just read through those and have an understanding that we can have, there are lots of different kinds of infectious and communicable diseases. Questions about that? All right, let's talk about our week 8 concepts: home care, community resources, case management. And then care of the chronic complex illnesses. I'm going to go through home care and case management in particular. Care of the chronic illnesses, complex chronic illnesses down here on page, I think it starts on page, I'm going to have you, I'll go through a little bit of it, but a lot of these chronic complex illnesses, I think you've probably been introduced to MedSurg. Okay, so I'm not going to go through those in detail. I want to focus on home care and case management, but do read through. I want to go through the first section of post-op. The rest, I'm going to have you read through all these other cirrhosis, COPD, type 1 diabetes, type 2 diabetes, peripheral artery disease, chronic venous insufficiency. Okay, I want to focus on home care and case management. What's home care? What's the difference between hospital care and home care? Where's home care provided?
In the comfort of home.
Yeah. It's in the client's environment. And the other thing about home care, it's individualized. It's individualized care in the client's home environment. Way back when, we used to consider home care as a priority for, say, homebound patients. But now, think about everything home care includes. Right? It could be primary, for a primary reason, for a secondary reason, for a tertiary reason. right? So in our primary, let's say we're doing home health nursing, trying to teach clients about their diseases, how to manage those diseases by training them on how to change a dressing or how to give an antibiotic report, right? Or helping them learn about their new diagnoses. Okay, we're trying to empower these clients to take care of themselves. That's the goal. We may be there to take care of them initially, but we are trying to, with teaching and education and training and teach back, we're trying to empower them to be independent and take care of their own whatever's going on. Right? We do want them, another goal of home care is providing all of what we just talked about so that they can remain in their home and not have to go to an assisted living or memory care or long-term care. Right? We're trying to empower them to be as independent as possible. One of the things that is different about doing an assessment in the home versus an assessment of a client in the hospital is if you're doing an assessment in the home, that's a much more detailed, longer, lengthy process because you may be having to work with family. And remember, you're a guest in their home. So you can't just walk in and expect to own the place. You have to walk in and start to develop that therapeutic relationship, right? Because if you're the one who's going to you're going to keep coming back, you want to make sure the client trusts you, feels like you're competent in what you're doing. Okay? It's home health in the home is about establishing partnerships with the client, the family, the neighbor, the friend, whoever's going to be helping out this client or whoever lives in the home. That's why it takes so much longer and it's more extensive. Omaha system. What is the Omaha? Go ahead. Somebody have a question? The Omaha system. The Omaha system was developed by Visiting Nurses Association decades ago. And it was developed because think about home health. Think about all the players, the insurance companies, the clients, their families, the services they need, the equipment they need. What else? These safety assessments that need to be done, medication assessments that need to be done. This Omaha system is a documentation system so that I as the nurse can go into the patient's chart with regards to home health and see what everybody else is doing. See what all the notes are. What did PT do this week? Did the port get changed this week? Are they off contact precautions this week when the nurse visited? Okay, so the Omaha system is about coordination of documentation. All right, and the Omaha system is most relevant to home health nursing and most typically used by home health nurses. The other big impact in home health is Medicare regulations, right? The responsibilities and functions of all the health professionals in home care are dictated by Medicare regulations. They're also dictated by state licensing boards. What is the scope of everybody's practice? Does it have to be an in-home visit? Can it be a telehealth visit? Can we do it on a consultation? Medicare, I wouldn't say decides all that, but all those needs are organized by Medicare. And their regulations will dictate what we can do, what we can't do. Right? So collaboration, interdisciplinary collaboration by all the players who are taking care of a particular client can be overwhelming, can be confusing, but it's a necessity. Right? Sharing information from one healthcare, let's say we're transitioning a client to go home, from the hospital to go home. Sharing information is critical, right? For community-based care, right? We have to know what those clients' needs are well ahead of discharge time. That's why we always say discharge planning begins at admission. Medicare program emphasize care for more acutely ill people rather than illness prevention. And that's an issue. So really what Medicare is really focused on the tertiary level. They already have something. They already have a diagnosis. Very little of the Medicaid guidance is focused on primary or secondary. Okay. Another tidbit about home care. The risk falling. When you go to a client's home, it's a wonderful opportunity to do lots of kinds of assessments. You can do an environmental assessment. You can do a safety assessment, fall risk, food insecurity risk, medication risk. What kind of environment does that client live in? When we're talking about falls, what are you looking for? Is the environment well lit? What are the rugs? Do they have carpet? Are there loose rugs that are moving around? Or is there furniture all over the place? Do they need handrails? Do they need a hand guard on their bed? If they're in a wheelchair, how do they get up? Do they need some kind of a belt restraint? All those things we need to think about. Okay. Community resources. One of the things as community nurses, we need to have a overarching knowledge about is community resources, because every client we visit or work with will most likely need some kind of a resource. And there are lots of resources in the communities, from food banks to rehabilitation programs to immunization clinics, health fairs, whatever. There's a gazillion resources in the community, but within your community that you're working in, you should have an accurate and detailed knowledge of what available resources there are. Right? Community resources are used to manage complex chronic illnesses, reduce vulnerability with the vulnerable populations that are all across our communities. Health departments work on this, nonprofit organizations, volunteer organizations. A few more examples: Meals on Wheels, Red Cross, clothing banks, food banks, crisis pregnancy centers, domestic abuse shelters, services that church or religious organizations provide, transportation services, and so on. So let's say we're working in a community that has a large population of non-English speaking people. Who would be, let's say you're the community nurse. There's a large, I'm just going to say Hispanic population that only speaks Spanish. I don't speak Spanish. I should have learned Spanish, but I didn't. So how am I going to care for that part of the community if I can't speak the language? Who am I going to look to? Who am I going to? That's one thing that the community nurse does. They partner with anybody and everybody that can assist them. Right? Community nursing is all about collaboration and partnership. So, who do you want on your team to help communicate to the Hispanic non-English speaking population that there are free immunization clinics, that you're not worried about immigration status, has nothing to do with it. You are welcome to go to these immunization clinics. You find people in the community that are working with this Hispanic population already, right? And you partner with them to help get the word out. Does that make sense?
Yeah.
It's a team effort. Community nursing is all about a team effort.
So I just got a question. So you're saying that team with the community to translate for a person?
Say that again.
So you're basically saying team up with the community to translate for a person?
Right. Well, let's say you
I thought you should always try to get like an interpreter, because
yeah.
I thought we was learned that people could always say different things.
Right. And that's what, sorry, maybe I wasn't clear. You seek out community members who work with this population already, who speak the language. So yeah, essentially an interpreter.
Like another healthcare provider?
Well,
or you mean like
let's say you need to communicate about an free immunization clinic coming in.
Mm-hmm.
Maybe who works with this community? You're out there, you're engaging with this community. You see there are church leaders. You see there's a food bank leader. You partner with those trusted community people who are already working with those populations and bring them onto your team.
All right, that sounds better.
Does that sound better the second time
Yeah,
around?
because in person we was always taught like don't accept information from another party.
Well, here's a good example of that.
Healthcare setting. I think she's trying to get us to like think about it in a community setting.
I get what she's saying now. Because she said like a trusted community person.
A trusted community person.
Yeah.
Guys, think about it. Here's a good scenario. Let's say you're working in a clinic in the community, okay? And you have a family that comes in that speaks, give me a language that I have no clue about. French. Okay, I don't speak French, but they have family members there. Because you can't assess what the family members can comprehend either, it's always best to try and find an interpreter, right? Rather than relying on family members. Now, if that's all you got, that's all you got. But it's always best to try and find an interpreter. Janisha, does that answer your question? Okay. The last section I want to cover is case management. What's case management?
Management of like if I need some extra assistance, there'll be somebody on top of me, not on top of me, but somebody above me, managing the things that I need: medicine, doctor's appointments, health visits, things like that.
Perfect. It's the coordinator of care. Nurses act in official roles of case. You may be the case manager of discharge planning. I just recently had a family member who was in the hospital for 5 months. They had a case manager, okay, because they had several complex chronic illnesses. Not everybody can be case managed, okay? There's not enough case managers to be case manage every patient. You know, if somebody comes in and has a triple bypass, they go home, no complications. They live with family members who can transport them to cardiac rehab, get them to doctor's appointments, cook for them, whatever. That patient doesn't need a case manager. But what if you have a triple bypass, lots of complications, has to go to a rehab center before they go home because nobody lives at home, they live alone. They have no transportation. They have all these other issues going on. Those are the kinds of clients that are case managed, the more complex, multi-need clients. Okay, we as nurses function as case managers officially and unofficially, right? We're always coordinating care. All right, case management involves individual clients. Okay, we're not case managing families, we're not case managing populations, we're case managing individual clients, right? These are, like I just said, high cost chronic diseases, maybe asthma, and not all patients that are case managed have to be in the hospital. We case manage lots of complex chronic clients in the community. Maybe clients with comorbidities of alcohol and drug abuse and mental illness. Maybe multiple chronic diseases, asthma, diabetes, COPD, cirrhosis. Case management is very labor intensive, very time consuming, and very costly. So the caseloads of case managers are typically the very high need clients. Okay. What's challenging with case management is all the fragmentation of services, because we may be working with multiple agencies, multiple equipment companies, multiple service provider companies, right? And sometimes that can be very cost ineffective. Is there overuse of services? Are there gaps? Is there miscommunication because there's too many people involved? Right? So case management, while it's very effective, can be very challenging. You know, it's like if I'm the case manager of the stroke unit, and I am the case manager for planning appropriate discharge, doing appropriate discharge planning of my clients going home. I want to make sure that I have an understanding of what every single client needs. And I want to make sure I'm the one that's making contact with all the services and agencies that's going to be needed when the client's going home. Right? It takes a lot of skills, communication skills, documentation skills, negotiation skills, conflict resolution skills. What if I'm having trouble with the OT because they can't come on the days that so-and-so has a family member there and they can't come on that day? How do I manage through those skills? How do I prioritize services with the clients? Right? How do I identify what resources the community has? Okay, so case management is coordination of care. You're going to work with multiple providers, seeking multiple resources for whatever your health outcomes you have put together for a particular client. So let's talk about a few different kinds of communication. Okay, you're going to get a question about this. Going to get a scenario on your next exam. It's going to say, is this collaborate? Is this
I have a
collaborate?
question
Yep.
before you moved on. I'm sorry. So I was reading in the notes and it had case management and then it also had care management. Are those the same thing?
No, care management. I updated these notes a little bit. Must be going
Oh,
back from
okay.
so use these notes. It was too
Okay, so
confusing. It's too
can you
confusing.
repost when you get a second, can you post that on the announcement so I can print it out tomorrow?
It was posted yesterday. I sent these notes on your,
Oh, you okay. I'm sorry.
yeah. Yeah, I took out the care management part because it was too confusing. And I wanted you to
Yeah,
really
it
understand.
definitely.
Care management is the big umbrella. Okay. How
Okay.
do you manage care? Case
Okay.
management is one component of that. So I didn't want you to confuse care management with case management.
Okay, that's cool. I'll reprint these out. Thank you.
So let's talk about different kinds of communication styles that a case manager might need to use. Believe it or not, they sound similar, but they're different. Collaborating. If you're collaborating, right? You're working towards a solution that basically satisfies the needs of both parties. You're collaborating. We're talking about what both of our needs are and trying to come up with something that's agreeable to both parties. That's collaborating. When you're communicating assertively, I'm being assertive by presenting my needs. Right? I'm being assertive. For me. All right? Assertiveness is what I want. Right? Cooperation is understanding what the needs of the others are, and you're cooperating. Whether you agree or not, you're cooperating. Does that make sense? Maybe you're cooperating with your fingers crossed behind your back or your nose, fingers over your nose, but you're cooperating. Okay, cooperation is basically the ability for you to understand what others' needs are. And then compromising. You finding a mutually acceptable solution that satisfies both parties. So you may not 100% agree, but you're compromising for the benefit of both parties. Okay? Does that make sense? What else do I want to talk about? I want to talk about undocumented residents. Okay? Trust in public health programs has to already be in place so that when a crisis situation occurs, things will run rather smoothly. So it's we all live in communities that have undocumented residents, right? And we need to make sure that they don't feel like they don't have access to services and resources in the community. For example, the example used in your notes, right? Let's say there's an immunization clinic and there's an outbreak of something. We need to be able to communicate to that undocumented community that please go get immunizations for your children. There's no requirement of immigration status that's going to be checked. And undocumented residents are in all our communities. So we need to have a plan of how we're going to work with them as well. Does that make sense? Post-op. I just want to mention post-op. A couple of things about post-op. This is in your care of chronic complex illnesses. I'm going to go through post-op and that's it. And you can read through the rest. We talked about aseptic technique. We talked about in one of our quiz questions. Oh, I wanted to talk about, this is what I wanted to mention, delegation. Okay. How do we delegate as LPNs, LVNs? Okay, delegating care of us as the LPN when you're delegating during the post-op period. Okay, there's a couple of things that need to happen. You need to give specific instructions as to what's to be done. How is it supposed to be done? How is it supposed to be reported back to you? And how are you supposed to accurately document it? Because when you're delegating It's under your license. So you need to make sure that those few things, what's to be done, how is it supposed to be done, what do you want reported to you, and what do you want documented? Okay, and then the last thing is you cannot assign patients who are unstable. You should know that, but I'm just reminding you. If a patient is in unstable condition, you cannot delegate or assign a client to a unlicensed person. Okay? Cirrhosis, you can read through COPD. This is that's hopefully a review for you guys. And it's 4:45, and I'm 3 minutes over because we don't take a break in this class. So we need to be done 10 minutes early. So I'm already 3 minutes over that. And I apologize for that. So we covered a lot today. We covered 2 weeks worth of material. You should be able to go back to your HESI prep. And I would say at this point,
Oh, wow.
80% of it can be completed. That's my estimate. 75, 80% of it can be completed. Because we only have one more week of content, and that's next week. I think we're talking about human abuse and violence, and I can't remember the other topic. We only have 2 concepts left to cover. Next week's it. So I implore you to take all the information up to this point and get going on your HESI prep or continue it. The concepts we've covered, some of the specific topics we have not. And that's where you go to your, probably most commonly, you'll be going to your med-surg book. Okay? So we didn't do the Kahoot, but I'm going to send the Kahoot. It's really good. I think it's really good. It covers both weeks 7 and 8. Okay, so I'll send that when I send the recording. I know we covered a lot. Has this been helpful?
Yes.
Yep.
Miss Marvel, is there any way that you can send all the Kahoots that you made?
I only have 2
Or-
so far. I sent one we had one in week 5, and this is the second one. I didn't do one. I should have done one for week 2, but I didn't. I ran out of time before class. So there's a week 5 one, and there's a week 8 one. And so if you go back and find your week 5 recording, that Kahoot is attached to that.
Okay.
And then the week 8 one today will be attached to your recording.
Okay.
Does that help? Okay. Does anybody have any questions? So now I'm 5 minutes over, and so I'm gonna release everybody. If you want to stay on and ask any questions, I'll be happy to stay on. But it's good to
Okay.
see everybody, and I hope you guys have a good week. And reach out if you need
No, come here.
anything. Anything. Okay? Have a great week.
Mom, you have a good week as well. Thank you. Come on, son.